So what I'm going to do today is talk through predominantly a COVID set of information, just to update you on where we are with that. And at the end, we'll have a sort of question and answer, which we'll do through the chat function there. So the sort of ground rules are, if you could please keep your microphone and silenced so that there's no sort of contamination of sound, so it's very clear. And then when we get to Q&A, if you submit your questions, then I've got a helper in Damien, who you can't see, who's off camera, who will sort of feed me the questions. Clearly, please keep them polite and respectful of individuals, and we'll try and do our best to answer as many as we can. And if there's some we can't answer or I don't know the answer, I have got other members of the executive team on this as well. I might pass you across to someone who might know the answer if I don't. And if none of us know the answer, we'll try and get back to you separately afterwards. Okay, so hopefully on the screen you can see some slides, and I think the key thing I want to say more than anything today is thank you. We've really done some extraordinary things in the organisation in the last few months. I don't think any of us could really have seen how this was going to develop, but all of that depends on the work that each and every one of our staff has put in. Despite the uncertainty and the anxiety and the strange ways that we're living under sort of social distancing rules, I think it's been absolutely fantastic what everybody's done. And because of all of that work that you've done and the organisational changes we've made, you know, we haven't been in that terrible position we feared, where we might not have been able to look after the patients coming in with COVID. What we've also seen, which I think has been fantastic, is how much the general public, and certainly within Rotherham, how much your efforts and the efforts of other key workers have been appreciated by the public. I think we see that every Thursday night, but I've also got some slides later on showing some of the sort of things that we've been sent to thank staff for the personal work they're doing. And you can't fail to see the rainbow logos on the roads outside the hospital, which the council and some other civic leaders put in place out of their own monies, that what they weren't paid for by the council. So it looks like we're now past the peak of the first wave of COVID, and that's good. We think we've probably passed that in South Yorkshire on the 8th of April. We've now started to see gradual falls in activity, and I've got some graphs in a minute which I'll show you that talk us through that. But if you think about the hospital at the moment, it's really totally transformed from what it would normally be doing, not least things like having a brand new 50-bedded critical care unit on A3 and A4, and the way that we've streamed from A&E, the way that the wards, AMU and others have got themselves divided into COVID positive and COVID negative areas. And really, we're running two services within one. I'm grateful for the fact that many of you will be working in places and ways that aren't your normal ones. We've had to do that to allow us to cope with this work. So thank you. Next slide, Damien, please. So this graph shows over a period of time from the 21st of March until the 5th of May, the rise and then fall of the number of newly diagnosed confirmed COVID patients per day. And I think it's fairly clear that we in Rotherham peaked at about the same time that the South Yorkshire system did, and the numbers have fallen. I think we'll see that fall in numbers continue slowly, but we might well be in a situation of having persistent numbers of COVID patients for a year or more to come, depending on as and when we get a vaccine in the future. Next slide. This shows the similar data, but this is a cumulative figure, and you can see in the greenish line, we've had 381 positive COVID patients, and you can see that starting to level off at the top. And sadly, we've had 118 inpatient deaths during that period of time. And of course, we know increasingly on top of that, there's been a very significant number of community deaths, particularly in care homes. And those aren't just statistics, those are individual people, and every one of those people who's been lost is a family member and is a tragedy for people, and colleagues and members of the local communities have not been able to go through the normal social process when losing a loved one of a funeral and so on. And so we want to make sure, as we do get through the COVID pandemic, that we do start to think about how we can support people to come to terms with any loss that they've had. Next slide, please. This is a snapshot of how many COVID inpatients we've got at any one point, first thing in the morning. You can see that we peaked at around 70 COVID inpatients in the hospital, and that's a bit less than the sort of 120 to 170 peak that was predicted, thank goodness. We're now down to a figure in the 40s, and so I think that progressive fall is likely to continue, but clearly there's some uncertainty depending on how the government chooses to relax the lockdown rules, which we think is going to start happening from Sunday and Monday next week. Next slide. And in ICU, again, we've had very significant numbers of ICU patients with COVID positive, particularly compared to normal ICU patients, and peaked at 12 here, but now we're down to 4. And so that's a very significant reduction. And again, it's likely that those numbers will fall further, but not go persistently down to 0 for some time to come. Next slide. Against that background, we've been trying to make sure that we swab staff where we can, and predominantly we've been able to do that without significant limit. We did have a short period a few weeks ago when the Sheffield lab was running short of reagents and had to limit that for a few days, but I think we're back up, and if anything, I think within South Yorkshire we were swabbing staff before national teams recommended it. And so, again, a lot of work's been done here by people on the COVID call line and also infection prevention control teams who've done an amazing job and worked very, very hard during this period to make sure those swabs got done and results back to people. Clearly, we have been working with less staff at work than we would normally have for a range of reasons, not just sickness, but we also have some staff who are being shielded. We've got other staff who have been self-isolating because they or a family member have got COVID symptoms, and I've done that myself for a period of time, and people will go into self-isolation and out again. But we're in a reasonably steady state of having about 400 people off at any one time, which is close to 10% of our workforce. I mean, thankfully, because of the flexibility of everybody else and the fact that our activity levels are a bit lower than they would normally be, we've managed to cope with that. So we're now starting to move to a different phase of the disease. It was pretty intense up to Easter. We're getting our preparation ready and all the work you did to restructure the hospital and our ways of working. We're now moving to phase 2, and this will be us trying to get as much normal work done as we can. Because if I had to so one of my top concerns is what's happening to the care of all those patients who've got other conditions other than COVID. We've seen a lot of people choosing not to come to the UECC, and even cancer referrals are down very significantly. And we need to make sure that we have those services in place for people who need them. Whilst we've had PPE throughout, we have been struggling recently to have enough sterile surgical gowns to allow us to resume surgical activity. And this is something which is shared across South Yorkshire and also regionally. So at the moment, we're still only really able to do urgent or life-threatening surgery, but we hope to be able to start to get more of those sort of definitive surgical operations up and running again before too long. And the next phase, of course, is also you're going to hear repeatedly this phrase, the 3 T's, test, track and trace. I think we'll hear more from the government on that shortly. But there's going to be a lot more testing done and likely to be contact tracing through public health. And also, I think there's been a lot of publicity about an NHS app, COVID app, that is being piloted in the Isle of Wight at the moment. Okay, so just a few images now just to show some things I think you'll be aware of. I mean, clearly, I think it's been a lovely gesture that the rainbow logo has been applied to the roads outside to recognise the work that everyone's done. We've had fantastic photos of staff responsibly socially distancing and taking part in the minute silence last week, and we've been inundated with gifts from people and businesses locally. Not many of them are healthy gifts. We've had more Easter eggs than we know what to do with, and I think curries and various things that have been well received, and we will continue to try and make sure that we distribute those in a sort of fair way across the organisation. Related to that, we're starting to receive quite a bit of charitable funds that the the Trust Charity will start to think about how to distribute those funds to the benefit of staff and patients over the next few weeks. We're very interested to know how you would think those funds should be used. So if anyone's got any thoughts on that, please feel free to email me directly at richard.jenkins8@nhs.net or through Anna Millinette or the charity or comms, and we'll coordinate those. We're also likely to put out a Survey Monkey shortly to ask people to give their views on how we should use those charitable funds to help our staff and recognise our staff. And again, we've seen some great stuff from local schools. We've got some lovely coloured pictures from many local primary schools in particular, which is great, and you can see some of those here. And again, I think we've seen some fabulous recognition from other members of the sort of public sector and emergency services for the work everyone's been doing, particularly on socially distanced clap for carers on Thursday evenings. And one more slide here, just again, just really showing that this is a human situation. This is about each and every one of you and us doing what we can to try and deal with this really unprecedented situation we find ourselves in. Okay, so thank you again for all of that. It is really fantastic, but it's not over, and we're going to have to keep doing this for some time to come, and therefore we need to continue to look after ourselves and look after each other. And we'll be trying to, as a trust, to make sure that we do that and recognise the contributions everyone's made. Okay, so hopefully that was clear. And I've had 2 submitted questions in advance, which I perhaps start off by answering. And then in the meantime, Damien, hopefully if there's any other questions coming in, can feed some to me. So the first one I've had is about annual leave. So the question says, just wondering what the policy on cancelling annual leave this year is, having booked some annual leave for June, July and September. I'm wanting to cancel due to the coronavirus and have them later on, but this has been declined in my department. So we looked into that, and I don't see any reason, having checked with HR, why someone shouldn't be able to cancel annual leave. I mean, in the normal run of things, sometimes our best laid plans do fall over for one reason or another, and annual leave gets booked and cancelled. Clearly, within a team, it's important that there's balance in that, and line managers have to look at how annual leave is shared amongst individuals and the timing of that, so not everybody can be off at once. But I think that should be possible to revisit that if the questioner revisits that with a line manager, and perhaps if there's any issues there, obviously that can be escalated up and we can see what we can do about that. One thing related to that, one thing I'm a little bit concerned about, of course, is that people may not want to take annual leave because what can you do at the moment? You can stay at home and you can't really go abroad or have a proper holiday. But equally well, we can't really get to the second part of the year and no one having taken annual leave. And it's also important for everyone's sort of mental health and well-being to have a breather and take time. So I would strongly recommend to staff that you do start to use some of our annual leave just to keep your batteries charged and spend time with family and friends if you can, even if it's virtually. And if everybody saves up all their leave the second half of the year, then we might run into trouble and not be able to always agree with everything that people would like to take. Okay, the second question I've had is about PPE, which I know is a big issue and is of concern to many staff. I would say before I get into the question that we've been compliant with the National Public Health England guidance on PPE, and the revised version of that, which was endorsed by the World Health Organization and the Health and Safety Executive and Medical Royal Colleges, I think we have to take as the right advice. But I'm conscious that clearly looking after patients can cause anxiety to people. And this questioner has said, other trusts in the region are offering staff significantly higher standards of PPE for staff on non-ITU wards. Colleagues at Doncaster Bassetlaw Teaching Hospitals are wearing surgical overalls, FFP3 masks, gloves and goggles on the acute medical unit, when here we're only offered a surgical mask, goggles, gloves and apron. I'd like to know the reason behind this difference. I thought if we all work for the NHS, we should be protected the same, regardless of which trust we are employed by. So certainly the last part of that is correct. We should all be complying with the same national guidance. On the back of that question, I did contact the Chief Exec of Doncaster Basketball Trust last night just to check this out, because again, I completely agree with the question. We shouldn't be doing things differently. And what he said to me was that the AMU there has done different things in terms of the service it's offered at times during the development of the COVID pandemic. And sometimes they were having hot areas and cold areas, and they've changed how they used it. So at one time they were using it for aerosol generating procedures, and including at times CPAP. And that was why at various points in parts of the unit, they have been using high levels of PPE. But he confirmed that as a trust, they are using the same levels of PPE we are. Richard Parker, who is the chief exec there, is the lead for PPE across the hospitals in South Yorkshire. And I have discussed this with him before about rumours about A&E staff at Doncaster wearing greater levels of PPE. And again, I've had those rumours discounted. So I think I have to take people at their word. But again, if people are concerned, and if you're concerned about your area, you haven't got the right PPE, then please discuss that with your line manager or infection prevention control. Okay, so Damien, have we got any other questions?
In community, we have noticed on occasions patients go into hospital for non-COVID related reasons, swab negative on admission, and then a few days later after discharge, we get calls and they are rapidly deteriorating and COVID positive. Are there any plans to swab patients on discharge in the future, or can we swab patients in community to get accurate figures for community as well as hospital?
Okay, hopefully everybody heard that. If you didn't, the short version is it's about patients coming into hospital COVID negative and then becoming COVID positive shortly after discharge, and asking about whether we should swab people on discharge and also in the community. I think what we're going to be seeing is a very significant rollout of testing shortly, and people will know that we've started testing every emergency admission to hospital a couple of weeks ago. We'll be testing elective admissions, and we are testing every care home resident on discharge, because obviously you don't want to discharge a positive patient to a care home without that being properly done in a safe way. I think we will start to see regular testing of a much wider range of people, but also in parallel with that, we should also start to see a reduction in the amount of COVID that's out there, so that those things will change. There are a lot of surveys going on at the moment of testing members of the public, NHS staff who are asymptomatic, and patients in general, to see what the frequency of carriage of COVID is. And we hope to get some more information about that from national bodies in the near future. It was partly because we can't be sure who's got it and who hasn't got it, that we instituted everyone wearing a face mask in clinical areas, even non-COVID areas, slightly about a week in advance of the national guidance to do so. Okay.
Why are we discharging patients that potentially have COVID before the test results are back?
Okay, why are we discharging patients who potentially have COVID before the test results are back? Well, we wouldn't keep someone in hospital just because they were COVID positive. They'd need to, be ill, requiring hospital treatment, because many people who have COVID infections will either be asymptomatic or have a very mild illness, or an illness that doesn't require hospitalization. So it's not necessarily the case that just because someone's COVID positive they need to stay in hospital. They would have to have some other reason to stay in hospital. So that I think that would be the case. And clearly it can take a week or more for someone to become COVID free after an infection. We wouldn't want to keep someone in hospital for a week just because they were COVID positive.
Does the Trust have a plan to protect vulnerable staff members when they are able to start to return to work, i.e. staff that are currently shielding? Okay,
this is a complicated area about protecting staff who are shielded, and we don't really know what the exit plan for that as we move through the further phases of this is. I think it's important that we try to support people to contribute and do as much of their work as they can if they are shielding at home, through remote working and so on and so forth. I've got Steve Ned, who is available on this Teams as well, and Steve might be closer to some of the thinking about what happens next in terms of shielded patients. So Steve, are you there?
Shielded staff, I think. I'm here. I don't know if you can hear me. I am here. I don't know if people can hear me.
I can hear you, Steve.
I'll proceed as if everyone can. So I think the issue is about shielded staff who are currently isolating for 12 weeks. And as Richard says, we need to await government guidance around what those staff do in the longer term. What I think we will be doing with those staff as they return to work is the same as we've done for other vulnerable staff, is conduct a risk assessment with their line manager in the place where they work to understand what the risks are, whether they can return to work, whether we can seek alternative working places for them, and or whether they can work from home. So the short answer to the long question is we would document a risk assessment for those staff if they are able to unshield and return to work.
Okay, hopefully that was audible to everybody and answered the question, but I think it's clear we don't have all the answers to some of these questions at the moment because it is something which is unprecedented and evolving. But I think one of the key things we're trying to do, and we are trying to do through the regular email comms and other comms, is to try and keep people up to date as things progress. Right, Damien, any further questions?
When do you envisage the return of services to Rotherham Community Health Centre?
So when will services go back to Rotherham Community Health Centre? It's difficult to answer that at the moment because I think that's really part of the next phase of recovery, but that will be something we'll be thinking about a lot over the next few weeks. So I think watch this space, but clearly we want to try and get as much of our services going again as soon as possible because there's patients who need our services. So again, we will have to get back to you on that as our plans become clearer.
What is the Trust policy on carrying over unused leave for the next 2 years?
Okay, so what's Trust policy on carrying unused leave over the next 2 years? Steve, I might go to you again on this one because this is going to be an important issue if people aren't using their leave.
Yeah, this is, again, hopefully people can hear me. This is not necessarily a Trust position. This is a national position. So there's been a change nationally within the NHS to allow more flexibility for staff to carry leave over, instead of over a 1 year period, it's over a 2 year period. And again, I think we haven't put some comms out about that, but we can certainly reiterate it. I would again come back to Richard's point, though, that we do want to ensure that colleagues take annual leave and don't store annual leave up over a 2 year period, because it's vital that staff, particularly in this current period, do take time away from work to relax and refresh themselves. So I think the advice we're giving to managers is that they should try to ensure that colleagues take leave on a proportionate basis, albeit there is a greater flexibility to carry leave forward over 2 years rather than one.
Okay, thank you.
We've seen some fantastic improvements using new technologies and new ways of working. Are we planning as an organisation to leverage this and embed these improvements post-COVID?
Okay, that's a really, really helpful question. So are we going to try and leverage these changes in technology use post-COVID? So the answer is yes. Today's experimental team brief is one of those. And I should say that be very interested in any feedback about whether this works for people and how you think we could develop it for the future. But yes, exactly. So whether that's video outpatients, consultations, and different ways of working remotely, we absolutely want to try and make sure that these things we've tried because of necessity and expediency, some of them will work and some of them won't, and we want to keep the ones that worked. Within the executive, we've already had a bit of a brainstorming session around that about what we want to do. But again, it'd be really useful to get people's feedback about what they think, what you think we might keep or not keep with this, and we're going to. That's going to be a key part of our sort of recovery planning over the next few months. So yes, absolutely.
A daily update is being given to my line manager, and I imagine to all other managers and clinical leads within the trust in regards to what is happening at the hospital daily and the amount of COVID patients. Could this be sent to everyone instead of just managers and clinical leads? Okay, so could we share data every day on COVID activity? I don't see any reason why we wouldn't do that. So that's should be a fairly easy thing to do. I mean, we're sending comms out every day, aren't we, I think, on COVID. So
I don't see any reason why we couldn't add in those key headline numbers to that. Damien's nodding off camera, so we'll start doing that from today or tomorrow.
Is there any further guidance or actions to be taken with regard to BAME staff groups?
Yeah, so this is about BAME staff groups and the very concerning evidence that's emerging about higher risk of severe outcomes from COVID if someone's from a BAME background. And given that we've got a very significant number of BAME colleagues working within the NHS, this is a really important issue. I think someone's ethnicity is one risk factor for a bad outcome in COVID. We know that others of those include the presence of underlying illnesses, male gender, age. There's a range of things there. So we will have already done risk assessments where necessary on staff, but hopefully people got the chance to see the letter we sent out on Friday last week, I think it was, about how we plan and how other trusts across the ICS are planning to pick up this issue there. We are expecting to see further guidance come out nationally on this at the moment. And Steve and I have been working quite closely to try and see how that's looking. But at the moment, you'll have seen a letter last week. We're asking any colleagues from a BAME background to speak with our line manager about having a reassessment of that sort of risk so that we can assess whether or not any changes need to be made to someone's working environment. I think this is a constantly evolving situation at the moment, and there's a new data came out today that was in the media again trying to quantify this risk. So we're keeping a very close eye on it, and we want to make sure as much as possible we act accordingly to protect our colleagues. Okay, so that's the end of the questions. So thank you for listening. I'm looking at the screen. I think we've had more than 130 people log on, which is fantastic. I'm very keen as Chief Executive that we do get really good channels of communication. And I think one of the things that concerns me about traditional team briefs in a sort of lecture theatre environment is you can only get a few people in, and it tends to be the same people every time. And I think this sort of way of doing things is a much more sort of democratic and open way of approaching things. And so I think what we will likely do is continue this at monthly intervals. But as I said earlier, really keen to get any feedback on whether this has been helpful, any ways you think we could improve it, or different ways you think we could develop it in the future. So thank you for logging on today, and keep well. Thank you.